Good afternoon, ladies and gentlemen, and welcome to this afternoon's webinar on embryo transfer and luteal phase support. As you probably know, this webinar is a joint collaboration between the Egyptian Representative Committee of the Royal College of Obstetricians, Gynaecologists, and the Middle East Fertility Society. We are very pleased, and I want to start by thanking the speakers, the international speakers who have taken out of their time to be with us today and share with us their extensive experience and their great knowledge, and we thank them very much. I want to also pay tribute to my colleagues in the Egyptian Representative Committee, the board members, 4 fellows and 4 members, Professor Gasser al-Bishri, Abdelgid Sarhan, Ahmed Zakaria, Hussein Abu al-Makarim, and the members, Dr. Wafa bin Jameen, Ahmed Mustafa, Marihan Halawani, and Dr. Sameh Salama. And we are also working in collaboration with the Egyptian Liaison Committee, UK-Egypt Liaison Committee, who are friends of Egypt, consultants in the United Kingdom, headed by Professor Muhammad Abdel Fattah, who is a professor of urogynecology in Aberdeen. Let me start by welcoming Professor Muhammad Yahya. For those who don't know, Professor Yahya, of course, is a professor of obstetric gynecology in Ancient University. He is a leading figure in assisted reproduction in Egypt. He has been doing IVF in the UK, in Saudi Arabia, and also in Egypt. He has a reputed IVF center, one of the largest in Cairo, the Queen's IVF Center. He is also the vice chair of the Egyptian Fertility and Sterility Society. And he will be talking to us about individualizing the standing dose of FSH in patients undergoing IVF. I would also like to welcome and thank Professor Peter Kovacs. Professor Kovacs from Hungary is a medical director of the IVF Center at Kali University in Budapest in Hungary. He is the first IVF in Hungary. He is also a former vice chair of the World Association of Reproductive Medicine, WAR, and he is very well known in his work on different subjects, including time-lapse photography in IVF. He's going to talk to us about embryo selection and the role of time-lapse monitoring. May I also thank and introduce Dr. Gautam Alabadia. You probably know him from the various books he is producing all the time, maybe about 10, 20 books so far. He is a consultant reproductive endocrinology in IVF, and he is known for his work in India and also in the Gulf. He does IVF at the Millennium Medical Center, the Hall Fertility Clinic at the Canadian Specialist Hospital, and Dr. Amal IVF Center in Dubai in the United Arab Emirates. He is the founder of the Rotunda Center for Human Reproduction in Mumbai in India, and he's also a vice president of the World Association of Reproductive Medicine WAR. And he will be talking to us about optimizing embryo transfer. Lastly, but not leastly, I want to introduce and thank Professor Omar Sifriwi. Omar Sifriwi is a professor and the head of the Department of Obstetrics and Gynecology at the University of Casablanca in Morocco. He's the founder of the ANFA IVF Center. He's also the first IVF in Morocco. He's the president-elect of the Mediterranean Society for Reproductive Medicine. And more importantly, he's the president-elect of next year's World Congress of IVF, which will take place in Marrakesh in Morocco. He's going to talk to us about optimizing luteal phase support. And may I also, lastly but not leastly, of course, introduce my dear friend and colleague, Professor Michel Abu Abdallah, who is going to be our co-moderator. We are going to moderate the event, both of us, and organize the question and answer session. He's the head of the Middle East Fertility Clinic in Beirut in Lebanon. He is a former fellow of McGill University in Montreal in Canada in reproductive endocrinology, infertility, and andrology. He's a co-founder, past president, and is a current executive director of the Middle East Fertility Society, MEFS, and he's also a member of the American Society for Reproductive Medicine International Committee. And I will leave Professor Michel Abu Abdallah to say something about the MEFS. I want also to thank Abbott for their sponsorship of today's webinar. They have been very helpful to us in all of activities. And may I take the opportunity of asking you to post your questions in the question answer section, not on the chat section. And please, if you like, mention your name and the country. I understand that so far we have about 1,400 registered, at least until this morning, and we welcome you all. And please, Professor Abu Abdullah, Professor Michel, you may like to say something about the Middle East Fertility Society and introduce the first speaker.
Well, once again, on behalf of my colleagues at the Middle East Fertility Society, we are pleased and honored to share these activities, and this is thanks to Professor Hassan Salam, my friend. These activities happen to be very successful, and this is what we see now as the high demand to join the activities. That means that you managed, Hassan, to give a very interesting program. The speakers are highly calibered, and I'm very happy and pleased to share with you the webinar. So welcome to the speakers and welcome to the audience as well.
Okay, so may I now introduce the first speaker, Professor Mohammed Yahya, who is going to talk to us about optimizing the FS test starting dose in patients embarking on IVF. Professor Yahya.
Thank you very much for the kind introduction. I'd like to thank you all and good afternoon to everybody. My talk today is going to be about how can we individualize the dose of FSH stimulation for any patient undergoing IVF. In the next 20 minutes or so, we are going to try to think about the optimal number of oocytes. Why do we want to individualize ovarian stimulation? What are the response categories? And what's the effect of FSH dosage on cycle outcome? What happens when we increase FSH in low responders? And what about the results of randomized controlled trials, which included individualization? And lastly, we are going to go into the topic, is more is less or not? We all know that as a part of IVF and exit treatment, we give exogenous FSH. And this is, of course, the aim is to obtain more oocytes, and then probably we aim to have more embryos. And of these embryos, we are going to have some of good quality to transfer them into the uterus. Studies have shown that among women with normal ovarian response, the live birth rate peaks with about 15 retrieved oocytes in fresh IVF cycles and remains relatively constant with about 16 to 20 oocytes retrieved. Usually, clinicians choose the FSH dose according to analysis of clinical criteria and lab results, and the most important being the outcome of previous IVF cycle. If there is no previous IVF cycle, then the choice would be based on criteria such as women's age, BMI, biomarkers, and the reserve of the ovary, antral follicle count, and other criteria we have. Currently used markers for ovarian reserve include FSH, AMH, and antral follicle count, with the last two markers giving the best performance of ovarian reserve response to exogenous FSH. We know that the antral follicles, the ones between 2 and 10 millimeter, are the recruitable ones. And these can be visualized and measured by transvaginal ultrasounds. And the total number gives us the antral follicle counts. And this estimates very good response, or what we think is going to be the response of these patients. Again, if we look at this historical data, the more eggs we get, the more embryos we generate. And this held constant throughout different time periods, starting from 1991 till 2006. And not only that, not the time periods only, but again, within every age group from 18 to 34 up to 40 plus. Not only that, we know now using CGH analysis, aneuploidy rate is not related to the number of embryo generated. It stays constant. It relates only to the woman's age. So if we are speaking about women less than 35 years, it's about 60%. It goes down to 13, 14% once we go into the age group of more than 42. We generally classify the response category into low ovarian response, and this is usually defined as the yield of less 4 oocytes. And this usually they have unfavorable prognosis of live birth, and such poor prognosis, in fact, is not only related to the number of oocytes, but to the higher age of this group in general. On the other side of the spectrum, there is a high response, and this is arbitrarily defined as obtaining more than 15 oocytes. This will jeopardize the safety of the patients and may even slightly limit the rate of live birth rate. Therefore, the aim of many clinicians is to steer the patient's response into what we assume is a normal range between 5 and 15 oocytes. So what's individualized medicine? It's personalized medicine, stratified medicine, prediction medicine, precision medicine. All of these are names of the same things, where the main focus of attention is to tailor a given medical intervention as much as possible to individual needs of the patients. And the aim, obviously, is to achieve the best clinical outcome with the least possible complication. So why do we think of individualization in IVF? Individualization of FSH dosage strategies are proposed to decrease the variability of ovarian response with the objective to improve effectiveness of IVF and exit treatment. These strategies rely on thinking or putative dose response relationship. If you give more FSH, you're going to get more eggs, more embryos. If you give less, you're going to get less eggs and less embryos. And this depends on the biomarkers, follicle cohort size to predict this response. A model based on antral follicle count, FSH, was able accurately to predict the ovarian sensitivity and accounted for 30% of the variability of ovarian response to FSH. Then came the nomograms. Nomograms calculating the individual dose of FSH, starting based on the patient's age, FSH, anti-Mullerian hormone concentration, and this subsequently was tested in a randomized controlled trial compared with the age-based standard FSH dose to prove the value of this individualization. But this brings us to what's the normal or standard dose of FSH. We know that going from only dominant follicle, a single dominant follicle, to maximum ovarian response, we need to increase the dose of FSH. How much? Between 50 and 225 international units daily. However, the actual serum level of FSH using this fixed daily dosage varies substantially across individuals. And there is a very small contribution of the body weight to this variation. Daily dose of FSH 150 is often promoted and in fact adopted as the empirical normal dose. This dose will allow optimal number between 8 and 15 oocytes in the large majority of ART cycles. However, with this dose subset, patients will produce either low or high response. What about increasing the dose of FSH and its effect on live birth rate? This was studies in fresh autologous cycles in about 650,000 cycles, huge number. And it was found that the live birth rate significantly decreased with increasing FSH dose, regardless of the number of oocytes retrieved. The statistically significant decrease in live birth rate with increasing FSH dose remained in patients with good prognosis, regardless of the female age. And this was, the only exception was in women more than 35 years and with less than 1 to 5 oocytes retrieved. The live birth rate decreased with increasing gonadotropin dose, regardless of the number of oocytes retrieved, across nearly oocytes and dose categories. The difference was significant at a very high 0.001 across nearly all oocytes group within the FSH dose categories, and within oocytes group across all gonadotropin categories for nearly all ages and within each group. And this was independent regardless of the protocol used. If you are using antagonist, agonist, it stays the same. What about this effect on frozen cycle? This was studied in a retrospective observational paired study, where it was found that the fresh live birth rate is negatively impaired by high dose of total FSH dose used as compared to live birth rate in subsequent fresh frozen embryo transfer cycles. Frozen transfer live birth rate seems to be unaffected by the total FSH dose used in fresh cycle, suggesting that it might be the effect of this exogenous FSH on the endometrium, and probably indirectly this high dose will only be affecting the endometrium in fresh cycles. If we come to low responders, this was studied in a huge amount of trial. One of them is the famous one that was in 2017, in which 511 women were randomized between antral follicle count less than 7 and between 8 and 10. And it was found that the cumulative, not only the fresh, the cumulative live birth rate for increased versus the standard dose, there was found no difference whatsoever. The only difference was that the patients who received a higher FSH dose had to pay about 1,100 euros to get the same birth rate. In women with predicted poor ovarian reserve undergoing IVF and ICSI, an increase of FSH dose does not improve the cumulative live birth rate as compared to the standard dose. As I mentioned, this study was criticized. Then came the Cochrane review, and it was found that it's now clear that the use of extremely high dosage of FSH, such as 300 to 600 international units, will not make any difference for the patients, but do have undesirable effect on the cost of the treatment. In predicted low responders, high FSH dose does not increase the number of retrieved oocytes. Usually it increases by 1 or 2 more oocytes, but substantially reduces the cancellation rate. It makes the doctor happy. The cancellation rate is less. You have maybe 1 or 2 oocytes. However, 8 randomized controlled trial failed to show any benefit from increasing the dose from 225 to 450 or even 600 unit on the live birth rate. The low responders may not have any benefit from dose adjustment. This is true for predicted low responders, the one we see low antral follicle count, but also it has no additional follicles to give, and this is very reasonable. But for the unexpected low responders, they will not have any better prospects in spite of high eggs that you can get 1 or 2 more. What about the other end of the spectrum, the predicted high responders? The real gain of individualized FSH dosing should be on the management of hyper-responding patients. Several studies have indicated that the use of sub-maximal dosage of stimulation will decrease the response of the ovary, and hence actually will give you reasonable number of oocytes without jeopardizing the efficacy and with real improvement in safety profile. So for the past few years, we have been actually thinking about the number. And this paper, which was published in Human Reproductions a few years back, stated that you cannot collect too many oocytes. Collect as much as you can, because actually whatever you are going to get, you can later use. And this was substantiated by a multi-center, multinational analysis, including 15,000 women, which showed that the more you have, the more you are going to get pregnancy chances, whatever the number, just get them. Then came the big, very well-controlled trials, 5 big randomized controlled trials, and so far studied the value of ovarian reserve testing based dosage individualization in general ART population, compared it to the standard dose. There is now moderate quality evidence for absence of difference between groups on the live birth rate. The end point here was actually to get live birth rate, not only the number of eggs or the frozen eggs. The incidence of moderate to severe ovarian hyperstimulation was reduced when compared to standard dose, but even this evidence was of low quality. And then came, for the past few months, the argument is more is better or less is more. Controversy continues to the optimal number of oocytes that should be retrieved, and whether more is better or less is more. It's widely acknowledged that the duration, extent of ovarian stimulation, the need for intensive monitoring, related frequent clinic visits, avoidance of treatment complications such as ovarian hyperstimulation, overall cost, and achieving better health outcome for both the mother and the baby are crucial for both patients and society. The argument is now we are using unidimensional approach, the live birth rate per cycle of treatment, and mostly involving fresh embryo transfer, without any measure of the importance of hyperstimulation, dropout rates, and the relative cumulative success rate per started treatment, health outcome for the woman and her baby, ultimate cost of IVF and its sequelae. And actually, the main point here is the dropout rates. It's quite apparent that a lot of patients are not going to continue because of the intensive monitoring and the pressure we put on them during the procedure. And in this month, Productive Biomedicine Live came an argument by Nurgand and Fauser, who are actually pushing for mild ovarian stimulation again. It's a cycle that's being repeated. And they think that this is the smartest way forward. And they stated that the balance between safety and efficacy based on number of oocytes retrieved. And according to the statistics they made, the live birth rate in fresh embryo transfer increased up to 11 oocytes. And then it evens out, while the cumulative live birth rate per oocyte retrieved, including both fresh and all subsequent frozen embryo transfer, increased up to approximately 20 oocytes. But the incidence of ovarian hyperstimulation syndrome, once we reach this limit, significantly increased with the number of oocytes. So in conclusion, Mr. Chairman, in low responders, you cannot rely and you cannot prevent it by simply increasing higher than normal dosage of oocytes, of FSH and pool, while high responders might benefit from FSH dosage reduction, mainly for safety issues. On this thought, with the option of triggering final maturation by GnRH agonist, whether with or without embryo transfer, deferring it to make it freeze-only cycle. These facts together, FSH dose individualization in our practice may become unnecessary, together with all the testing we are doing for the patients, with the with the cost of monitoring, blah blah blah. And maybe just we need to reevaluate our practice from more is better into less is more. Thank you very much, Professor.
Thank you very much, Professor Mohammed Yahya, for a beautiful presentation. And I will take the privilege of asking you one question, and then we'll leave the rest of the questions at the end. We have a question from Dr. Muhja Falah. I think she's from Jordan. She's asking about this effect of high FSH dose. Is it due to premature progesterone rise, or to another effect on the endometrial receptivity, or is it on the top quality embryos? I mean, why is the high dose?
I don't think it has anything to do with the quality of the embryos, because actually when you retransfer on the frozen cycle, it didn't have any effect. And I am not quite sure about the progesterone effect, because actually it works in whatever protocol we are using. We know that the antagonist protocol, you might have a little bit more of premature progesterone rise, but the same criteria was found in the agonist protocol. So it's mainly the effect of exogenous FSH on the endometrium.
Thank you very much, Professor Mohammed Yahya. I will leave now Professor Michelle Abu Abdallah to introduce our next speaker. Michelle, unmute yourself. You're muted.
Hassan, I lost the sequence of the talks. Who's next?
Professor Peter Kovacs.
Ah, okay. Well, I'm honored. I'm honored to present Professor Peter Kovacs. Peter is well known, as you said, Hassan. He has published many papers, interesting papers in the peer magazines. And now I would like to welcome him to lecture for the audience in the Middle East and probably somewhere else. Professor Peter, the floor is yours.
Thank you for the invitation. I'm going to try to get my presentation up. I hope that you can see it now.
Yeah.
Okay, so first of all, I would like to thank Professor Salam and to all the organizers for inviting me to this webinar. And I'm going to talk about the role of time-lapse monitoring in embryo selection. I think that we all agree that the ultimate measure of success during assisted reproduction or IVF is a successful birth of a singleton full-term child. We are all aware that multiple gestations are associated with increased maternal and neonatal risks, as well as increased costs. And this is mainly true for high order multiples, but for twins as well. And we can also agree on that we can only guarantee a singleton pregnancy if a single embryo is transferred. What is it that we do during in vitro fertilization? We heard a nice presentation about the use of stimulation. In most cases, we do use stimulation, an individualized approach with the aim of trying to get somewhere between 10 to 15 oocytes. We then fertilize these eggs, create multiple embryos, and we culture them for a number of days. And ultimately, we would like to choose one or most two embryos to be transferred. And if we look at the transfer practices, then we are still not at the universal single embryo transfer level yet. If you look at the most recent US data, which is from 2018, we can see that in the youngest age group, under 35, the mean number of embryos transferred was 1.3, and in the eldest age group, it was 2.3. In Europe, we have data from 2016. In about 60% of the transfers, 2, 3, or even 4 embryos were transferred. And if you look at the outcome of these IVF cycles, so even with these transfer practices, the success rates have remained relatively low. In the under 35 age group in the US, the live birth rate was 42%. And this is actually down to under 3% once the patient gets over 42. It is also true that across the different age groups, the twin rate was down to 5 to 10%. In Europe, the clinical pregnancy rate across all age groups where embryo transfer was 1 in 3, with about 16% of these pregnancies, multiple pregnancies. So how do we identify the embryo to be transferred? Still, the most common technology is a evaluation by the embryologist based on once a day or based on twice a day assessment of embryo morphology, when cleavage rate, fragmentation, embryo morphology are looked at. And the embryo to be transferred is selected based on its actual developmental stage on the day of transfer. In a way, we can leave this up to nature, and we can use extended culture and see which embryos are the fittest and make it to day 5 and transfer a blastocyst. There are invasive technologies, pre-implantation genetic testing for aneuploidy, which may aid embryo selection. There are other omics technologies, and obviously there's time-lapse technology. So time-lapse technology, what this means is that it is a digital camera that is either part of the incubator or is put in a standard incubator that takes images of the developing embryos at preset 5 to 20-minute intervals. Most of these units come with a custom-made software that creates a film based on these images, and you can analyze it as long as you want it. You can fast forward it, rewind it, you can blow up the images and look for all those changes that an embryo undergoes from fertilization to transfer. Some of these time-lapse units already come with built-in algorithms that help the biologist select the embryo for the transfer. Now, time-lapse technology has 2 clear benefits. It allows continuous embryo monitoring without the need to remove the embryo from the incubator. And this is very important because when you take the embryo out of the incubator to look at it underneath the microscope, you remove it from the optimal temperature, gas composition, pH, humidity conditions. And each of these changes are a stress to the embryo. So you have limited opportunities to look at the embryo if you use standard microscopic evaluation. In addition to this, a lot more data can be collected based on an embryo. Just imagine that you take 3 images per hour. That's 72 images per day versus 1 image if you look at the embryo just once. And with the help of these images, you can look for dynamic changes. You can look for things that you otherwise would not see, such as appearance and disappearance of fragmentation, changes in blastocyst morphology, collapse of the blastocyst, pulsation of the blastocyst. You can look for multinucleation. You can look for normality of the cleavages. Some embryos display abnormal features of cleavages, such as direct cleavage, reverse cleavage, cell lysis. And you can look at the kinetics of the cleavages. This is an image of an embryoscope, which is slowly becoming the standard of care if you use time-lapse technology. And the current units come with their own algorithm. There's a day 3 and a day 5 algorithm. KIT stands for known implantation data, and there's a built-in algorithm that helps the biologist to select the embryos. The latest version of EmbryoScope can actually monitor 15 embryos of 15 patients and 16 embryos per patient. So this is could be a very useful tool. But there are other units as well, and I don't want to go through all the details of this slide, but there's the Primovision, Gary, ESCO, Miri, and the EVA system. They use different illumination. Some of them are an incubator with an integrated time-lapse system, such as the EmbryoScope. Others are a microscope that need to be placed in standard incubators like the Primo Vision. They all come with unique culture dishes. These culture dishes sometimes allow group culture. In other cases, you use individual embryo culture. And most of them come with custom-made software. So the parameters that you can look for using time-lapse technology is time to a certain developmental stage. So time to pronuclear fading, to 2 to 3, 4, 5 cell stage, to morula formation, to blastocyst formation, start of blastulation, the time that it takes the embryo to reach the full blastocyst stage. Usually the starting point where you start measuring time, in case of ICSI, is the midpoint of the ICSI fertilization of the cohort. With IVF, it is the time when you add the sperm to the oocytes. In other cases, you use better defined starting points, such as time of, you start from pronuclear fading, for example. In addition to these kinetic parameters, you can look for duration of the cell cycle, cell cycle 1, 2, 3, and you can also look for the synchrony of these divisions. Now, the early studies that used time-lapse technology just were descriptives. They just described how long it took an embryo to reach certain developmental stage, but the embryos, if transferred, were selected based on actual morphology. Subsequent studies tried to correlate these kinetic markers with some kind of outcome, such as blastocyst formation, implantation rate, clinical pregnancy rate, or live birth rate. And eventually randomized controlled trials were performed. Some of them only compared the culture conditions. So they cultured embryos in a time-lapse unit versus in a traditional incubator and looked for outcome. Others compared algorithm-based selection versus morphology-based selection among embryos cultured in time-lapse units. And there are a few randomized controlled trials that actually evaluated the full benefit when you culture the embryo in a time-lapse unit and you use an algorithm for embryo selection. And eventually meta-analyses were published, actually quite a few of them. And there are a lot of opinion papers, a lot more than randomized studies performed in this topic. So if you look at the studies, and I'm just gonna talk about a few of the studies. So if you look at those studies that compared time-lapse culture versus culture in a standard incubator, Cruz and colleagues used donor embryos that were conceived using donor oocytes, and they randomly assigned them to culture in a time-lapse unit versus culture in a standard incubator. And similar day 3 and day 5 development was achieved in both incubators. Park and colleagues performed a randomized control trial. The embryos of 364 patients were randomly assigned to culture in a time-lapse unit versus standard incubation. Embryos were cultured to day 2. Single embryo was transferred on day 2, and morphology was used for embryo selection. And again, the proportion of good quality embryos, pregnancy rate, and ongoing pregnancy rate were comparable. So we can conclude based on these studies that culturing in a time-lapse incubator is safe. Early on, there were concerns that by taking these images, you expose the embryo to too much light. But in fact, you expose the embryos to less light if you take these images versus taking them out and evaluating them under a regular microscope. And in addition, it avoids the harmful short wavelength. Now, if you look at those studies where the culture conditions were similar, but the embryo was either selected based on an algorithm or based on morphology, then again, there are two studies that I would like to talk about. One of them is a randomized control trial by Goodman and colleagues. They randomly assigned 287 patients to morphology versus algorithm-based selection. All embryos were cultured in EmbryoScope. And in the morphology group, there was once a day assessment, and the embryo was evaluated on, chosen based on day 5 morphology. And in the algorithm group, in addition to the once a day assessment, morphokinetic data time to the 5 cell stage, time to start of blastulation, cell cycle 2, and the second and third synchrony, as well as cleavage anomalies were considered. And what they found that with the 2 selection methods, similar pregnancy and implantation rates were achieved. Kaiser and colleagues did a similar study, but they used a different time-lapse system, the EVA system. The embryos of 163 patients were all cultured in the EVA system. The EVA system uses an algorithm based on early markers that predicts blastocyst formation. And a single embryo was transferred in these groups. In one of the groups, selection was based on day 3 morphology plus the EVA score. And then in another group, there was day 5 morphology plus the EVA score. And in the third group, there was day 5 morphology alone. And again, the clinical outcome was comparable in the 3 groups. So what we can conclude based on these studies is that the use of an algorithm alone is probably not giving us the full benefit, as it does not seem to impact on the clinical outcome. So there are other randomized controlled trials that test the full benefit of time-lapse technology. So they compare time-lapse culture versus standard culture, and in the time-lapse system, they apply an algorithm to select the embryo. The problem with these studies is that there are different time-lapse units used, EmbryoScope, PrimoVision, or the EVA system. There are different time-lapse parameters that are included. Some rely on early markers, others rely on kinetic markers plus morphology as well. There are different patient populations tested. Some include only young patients. Some include only cycles using fresh oocytes. Others include cycles using frozen oocytes. Some include patients using their own eggs. Some include patients using donor oocytes as well. And the culture conditions are not always similar, especially when it comes to the oxygen concentration. There are different algorithms used. I'm going to talk about 4 different algorithms, and there are more algorithms that have been tested. But one of the first algorithms that is widely used is the algorithm proposed by Meseguer and colleagues. They built a decision tree based on early kinetic markers, time to the 5 cell stage, the duration of cell cycle 2, and the second synchrony. And they also used deselection markers such as direct cleavage, multinucleation, and uneven blastomeres. Wang and colleagues used the EVA system, and they also used early kinetic markers, and their algorithm predicts blastocyst formation. I'm going to talk a little bit about our study in a second. And I want to mention that there's an algorithm proposed by Peterson and colleagues. This is the so-called KIT score day 3, when they use various mathematical formulas calculated based on early kinetic markers and cell count at 66 hours. And they scored the embryos into 5 different categories. The nice thing about this algorithm, and I'll talk a little bit more about this later, is that the data were collected for this from 24 different clinics using their own culture conditions. So they propose this as a universally applicable algorithm. Now, talking about our own trial, we included young, good prognosis patients who agreed to single blastocyst transfer. And we randomly assigned them to standard incubation and morphology-based selection versus incubation in a time-lapse system, and we used the PrimoVision system and a time-lapse score. We had a composite score that included early kinetic markers plus blastocyst morphology. We gave points for these, and then we deducted points for abnormal cleavage patterns. In total, 161 patients were randomized, 22 dropped out for various reasons, and 139 completed the study per protocol. Baseline and stimulation parameters were comparable. In this graph, only look at the left 2 columns. Later on, we added a third group, which was a group selected based on similar inclusion criteria, who actually had 2 embryos transferred in the same time period. But if we compare the time-lapse group, which is the left two columns, and the control standard groups, we'll see that the pregnancy rate and the clinical pregnancy rate were higher in the time-lapse group, but these differences were not significantly different. So what do we do when we have a lot of studies and there's no concluding evidence? We perform a meta-analysis. And again, I'll talk about two of these meta-analyses. One of them is the 2019 Cochrane review by Armstrong and colleagues. They considered 9 randomized controlled trials for the Cochrane review, and they did various analyses. So they separately included studies where there were only culture differences. They separately included studies where there were only embryo selection differences, and then they separately included studies where the full benefit was tested. In this last comparison, only 3 randomized controlled trials were included, and they considered the evidence to be very low quality. They found no difference in the live birth rate, and they found a lower miscarriage rate in those cases where the embryos were cultured in the time-lapse unit. In 2017, Pribensky and colleagues published their meta-analysis based on 5 randomized controlled trials, in total of over 1,600 patients. And they reported higher ongoing pregnancy rate, lower early pregnancy loss rate, and higher live birth rate with the use of time-lapse units. So now we have these algorithms, and obviously it would be nice if we could all use these algorithms. So a number of studies were published that tried to utilize these algorithms in their own labs. And unfortunately, these studies typically failed to prove the benefits. Frere and colleagues tested the Meseguer model in 450 unselected patients, and across the different morphokinetic categories, they got very heterogeneous implantation rates. Kierkegaard tested the EVA model. It, in a way, predicts usable and non-usable blastocysts based on embryoscope data. So again, they used an EVA model, which is a different time-lapse unit, and they applied it into embryoscope, which is a little bit different technology. They tested over 1,500 embryos, and they agreed that those embryos that were considered usable were more likely to implant, but half of those embryos that implanted were classified by the system as non-usable and could have been discarded if we agreed to the assessment of the system. Finally, Berry and colleagues tested 6 different algorithms, and they got a very wide range of sensitivity and specificity with them in their own patient populations. So we can say that an algorithm built on one patient population in one clinic is not readily transferable to another clinic. So we need universally applicable models. And I already mentioned this Peterson model. Now the data is based on over 3,000 known implantation data embryos. I mentioned that early kinetic markers were used to create mathematical formulas. And based on this, a score between 1 and 5 is given to the embryos. 1 is the worst, it's the lowest implantation rate at 5%. With a score of 5, the implantation rate was 36%. And subsequently, using similar multi-clinic data, day 5 KIT score was developed, and there are now a second and a third version actually of this KIT score day 5, and the embryoscope is equipped with this. This algorithm, however, has not been validated prospectively yet. I think that most of us will agree that in the majority of the IVF cycles that fail, we blame the embryo, and we say that the embryo that was transferred not knowingly is probably aneuploid, and that is why the treatment fails. So it would be nice if we could identify the aneuploid embryos based on various time-lapse parameters. And early studies were promising because Chavez and colleagues have shown that aneuploid embryos follow a less strict developmental pattern. They are more likely to be very fast dividing or slow dividing, or start out slow and then they start to develop quickly. So they follow a more chaotic pattern of development. Subsequent studies try to correlate early and late markers, kinetic markers and genetic status, and some studies did find associations, but others could not confirm this. Similarly, conflicting results were published when the cleavage pattern of the embryos is looked at. Those embryos that display more than one abnormal cleavage pattern, especially chaotic cleavage and cell lysis, are more likely to be aneuploid. But there's a huge overlap between euploid and aneuploid embryos, so we cannot use time-lapse technology alone to say which embryo is aneuploid and which one is healthy. So the question is whether we have missed something using time-lapse technology, because the benefits of the technology seem to be valid and sound, because the undisturbed culture and the numerous observation points should help us identify the embryo to transfer. So why is it that the randomized control trials, and even if we look at the meta-analysis data, are not supporting huge clinical benefits? There may be some benefit getting to clinical pregnancy when we talk about clinical pregnancy rate or live birth rates. So are we looking at the data that time-lapse offers properly? And I keep on talking about the lot of information that time-lapse can provide us. And this much information is probably too much for a biologist to handle. So whenever it is too much for a human being, we turn to computers. And artificial intelligence has been introduced in time-lapse technology in recent years. So artificial intelligence is any computer science that performs cognitive tasks like we human beings perform. This means that the system, as it keeps on repeating its tasks, learns how to interpret the data and gives us predictions with ever-increasing accuracy. So machine learning is the study of computer algorithms that improves automatically through experience. So actually the machine learns and is able to better identify the outcome that we look for. And deep learning is actually the technology. These deep learning artificial neural networks mimic the human nervous system. It learns from large amount of data. There are these neurons that are organized in multiple layers. These different layers transfer their input differently, and the signal travels back and forth before we get an output from the system. And it is important that these systems are data driven. We don't tell them what to do, we give them the data and they analyze the data. So there are a number of studies that looked at the benefits of artificial intelligence in embryo selection. And this is not a time-lapse study, but one of the studies that was published this year by Dr. Chavez Badiola from Mexico tests an AI model called ERICA. This is Embryo Ranking Intelligent Classification Algorithm to predict pre-implantation genetic testing and ploidy results. What they did, they used a standard microscope and they took static images of blastocysts, over 1,200 images. There were 840 embryos that had known ploidy, and there were 156 that had known beta HCG. They trained this data set into a training set and then a testing set. And on the testing set, the ERICA system obtained a 0.74 area under the curve for predicting euploidy, which is a relatively high predictive ability. When they use this system to rank the embryos, in almost 80% of the cases, the system identified a euploid embryo at top of the ranking. And if you looked at the top 2 blastocysts, then in almost 95% of the cases, a euploid embryo was selected. But again, this analysis is using just a single image. So what if we want to use multiple images? And this is what Khosravi and colleagues did. They used the EmbryoScope timeless blastocyst images, over 10,000 embryos, there were 7 images per embryos in different focal planes. They used a deep neural network system called STORC, where 70% of these images were used for training and 30 for testing. They had embryologists score these blastocysts as good, fair, and poor. They omitted the fair group, and they wanted the system to predict good or poor quality blastocysts. And they had per image they had a 98.7% accuracy, and per embryo 97.5% accuracy, identifying good or poor embryo quality. And then they had a separate subset of images, almost 400 embryos, and they had 5 embryologists score them, and then they used the majority vote. And in 95% of the cases, the STORC system predicted the majority vote, while agreement with the individual embryologist was a lot lower. They also used data from other clinics, and there was still, the system worked still well. In 90% of the cases, good quality embryos were identified, while in 70% of the cases, the poor quality embryos were correctly identified. And then this is probably the most important study so far published on AI and time-lapse technology. Tran and colleagues included whole time-lapse videos, and they wanted the system predict which embryo was going to result in a fetal heart, so an ongoing pregnancy. The input into the model is just the raw time-lapse recording, unedited time-lapse recording. And the output is a number between 0 and 1, which is the likelihood of the embryo transferred leading to fetal heartbeat. They early on randomly chose the weights of different events, and as the system learned, they made these predictions more precise. And once the system was trained, they used a testing data set. And on the testing data set, the system was 93% accurate in identifying the embryo that was going to result in a heartbeat. Now, I know that on a completely different independent data set, the system called IVY was not this accurate, but this IVY system is now being tested by Vitrolife, and they are using over 100,000 time-lapse recordings to develop a different AI algorithm, and this is going to be included in the embryo scope. So what we can conclude that time-lapse offers safe, undisturbed culture conditions and eventually continuous monitoring of embryonic development. The proposed algorithms typically do not work well when they are tested in other labs, and the suggestion was that each clinic should develop their own time-lapse algorithm, which is not very practical, especially for smaller clinics. But there's a lot of data that can be analyzed. And if we use the help of artificial intelligence, then we can probably develop models where we can identify the embryos that are euploid or that are likely to result in an ongoing pregnancy and eventually live birth. So I see in the near future that time-lapse units will be equipped with algorithms that are built with the help of artificial intelligence. And this IDA score is Intelligent Data Analysis Score, is now being prospectively studied, and hopefully within the next year or two will come out and will help the biologists select the single embryo to be transferred to result in singleton pregnancies and many happy couples. So thank you very much for your attention.
Thank you very much, Professor Kovacs, for a beautiful presentation. There are plenty of questions, actually, but let me start by one now, and then we'll leave the rest to the end of the presentation. There is something you have referred to, which is reversed cleavage. What does this mean? Do you mean you can see today the embryo is 4 cells, and after a few hours it's only 2 cells?
Exactly. This is what you can see, that there's an embryo that starts to cleave, and all of a sudden the cell number gets smaller. So from 3 it goes back to 2 cells, and then it starts to divide again. So this is something that you typically would miss if you looked at the embryos just once a day, but something that can be seen using time-lapse technology.
Yes, but what is the explanation? How can it be 4 cells and then become 2 cells? Maybe it is an artifact.
It could be an artifact, or could be that cells undergo apoptosis, and rather than splitting, they just undergo apoptosis. They disappear, and then other cells give rise and continue to divide and increase the cell number within the embryo.
All right. Thank you very much, Professor Kovacs. I will now leave the floor to Professor Abu Abdallah, who is going to introduce our next speaker. Michel, you are.
Hi. I'm honored and pleased to introduce the next speaker, Professor Gautam Al-Ahbadiya. Professor Gautam is a consultant in reproductive endocrinology and in vitro fertilization at the Millennium Medical Center, Bournehall Fertility Clinic. Also at the Canadian Specialist Hospital and Amal IVF Center in Dubai, UAE, and founder of the Rotunda Center for Human Reproduction in Mumbai in India. Professor Gautam has many publications, interesting publications. Also, he has a training center for physicians who want to train for in vitro fertilization practice, and as well in parallel for embryologists. I'm pleased to introduce Professor Gautam, friend of us and friend of the Middle East Fertility Society as well. Gautam?
Gautam, you are muted. You have to unmute yourself.
Thank you. Thank you for your kind introduction, Professor. Is it all okay now? Is the screen shared?
Yes, the screen is shared and we can hear you well.
Perfect. So this is a topic very close to my heart, optimizing embryo transfers. We've been working and researching on this topic for over 2 decades now. So instead of a lot of literature review, I'm going to show you a lot of practical videos in this lecture, which I am sure will benefit the beginners and interest the already practicing people in the field. So over the past few years, IVF results have improved in terms of implantation, pregnancy rates, basically due to tremendous efforts in improving individualized stimulation protocols, improving the laboratory techniques, culture conditions to get better quality embryos.
Gautam,
yes.
Gautam,
yes.
Sorry to interrupt. May you focus the camera at your computer?
Is it not on the
A bit focus. Yeah. Well, it's not clear.
It is okay with us, Michel. I can see it properly.
Yes, I can also see myself properly.
Okay. All right. Okay. Now it's better.
Yeah. Okay.
So over the past few years, IVF results have improved in terms of pregnancy rates due to individualized controlled stimulation protocols, lab techniques, culture conditions, vitrification. However, very little attention has been focused on embryo transfer techniques. There are less than 200 publications on embryo transfer techniques in 2 decades when you compare them with over 20,000 publications on the other aspects of improving pregnancy rates. Various facets of embryo transfer practice may improve implantation rates, but what are the most important? The most important have been listed by William Schoolcraft, who said avoiding excessive contractions and trauma to the endometrium are considered to be the principal factors in improving embryo transfer rates, pregnancy rates after embryo transfer. So you have to be as gentle as possible. What are the main variables that influence the success of embryo transfer? Number one, absence of blood or mucus on the outside or inside of the transfer catheter. The type of catheter used, I personally very strongly believe, with I think over 3 decades of practice, that the softest possible catheter gives the most atraumatic embryo transfers and is best used for IVF. Not touching the fundus. The level of the deposition of embryos in the uterine cavity, the amount of fluid volume that we use when the embryologist loads the catheter and gives it to the clinician. Never use a tenaculum. The training of the doctor who's doing the transfer. The impact of subendometrial myometrial contractions if you happen to touch the top of the fundus if you are doing a transfer without ultrasound guidance. How long should you hold the catheter in the cavity before withdrawing the catheter? Is prolonged bed rest after transfer mandatory? Should you always do a trial transfer? And I feel the most important is ultrasound guided embryo transfers. This should be the norm and the gold standard in 2020. Remember, the procedure of embryo transfer is very routine in 95% of cases, but 5% of cases can be very problematic. What are the problems? The problems encountered include patient nervousness, a narrow introitus at times, cervix that is flush with the vaginal wall, cervical stenosis, a patulous cervix, cervical distortion, false passages. This is very common, especially if people have attempted hysteroscopy pre-transfer in a previous month and have, with the dilator, created false passages which have fibrosed and abnormalities of the uterine cavity. So mandatory measures such as use of ultrasound in guiding embryo transfers, trial transfers, cervical dilatation always remote from the embryo transfer in the previous month, using specialized catheters and occasionally resorting to transmyometrial or tubal embryo transfers in selected, highly selected cases improve the outcome of patients with a history of difficult embryo transfers. So let us, understand how gentle one has to be. 23 infertile patients underwent a mock transfer just before a microhysteroscopy with the Tomcat catheter, which is a hard catheter, a Friedman's catheter, which is next to the Tomcat in terms of stiffness, a Friedman's set, which is a little softer, or the Wallace's catheter with the ultra floppy tip, which is the softest. The lesions in all 23 patients were described and documented as tunnel-like, groove-like, punched out, or crater-like with this microhysteroscopy. The Wallace ultra soft tip floppy catheter appears to be less traumatic to the endometrium than the stiffer catheters. And if you go, and the conclusion was that some of these observed lesions appear to be capable of compromising the success of embryo transfer. Now going one step further, a mock embryo transfer was performed by a single clinician, immediately followed by saline hysteroscopy using a 2.7 millimeter hysteroscope. No dilators or uterine sounds were used. Out of the easy transfers, 54% showed no endometrial damage. However, 37% showed moderate to severe damage even in the easy transfer group. So clinical perception of ease of transfer does not correlate well with the degree of endometrial disruption. So what really helps? It is ultrasound guidance helps in the proper placement of the embryos in the uterine cavity. On a partially full bladder, a trans-abdominal ultrasound guidance is much better than a blind embryo transfer where you have chances of touching the fundus or the tubal ostia by almost 25% times. Suboptimal catheter placement like subendometrial transfers, tubal transfers, to embedding the transfer catheter within the endometrium has been noted when you do transfers using clinical touch that we call blind embryo transfers. The proper placement of the embryos 0.5 to 1.5 centimeter from the fundus using ultrasound guidance has shown dramatically improved pregnancy rate. This is a paper from Brazil, which went one step further and showed that even when you're using ultrasound guidance, increased implantation and pregnancy rates can be obtained by placing the tip of the transfer catheter in the central area of the endometrial cavity. And this is a very interesting paper from 2004, which is still relevant today. This is an old paper in 1985, where Strickler compared 16 transfers done under ultrasound guidance to 12 transfers which were performed blind by clinical touch, and reported that the use of ultrasound not only helped in positioning the catheter tip in the fundus of the uterus, but it also documented the fluid bubble. In the 1980s and early 90s, it was called the fluid bubble. Now it's called the embryo flash. So when you use an ultrasound, you can document the fluid bubble, and this is reassuring both to the patient as well as the clinician. So what exactly is the fluid bubble? Let me show you this video. This is a normal Wallace non-echogenic floppy tip going up into the uterine cavity. This is the loaded catheter. Once in the early 90s, we were trying to place the embryos about 0.5 centimeter from the fundus. But again, we can watch this. Watch this area, the catheter, the floppy tip catheter going up, and the embryo flash or the fluid bubble is the air with the culture medium that is deposited at the place where you want to deposit it. So after deposition here, you withdraw the catheter, but what you saw was a movement of this fluid bubble or embryo flash, which is downwards. So in cases of pregnancy achieved through embryo transfer, approximately 80% of embryos implant in areas to which they are initially transferred, and approximately 20% implant in other areas. This was determined using 3D ultrasound very early in Japan. And when we were doing using regular gray mode ultrasound, we noticed every time we deposit the embryos, there is the embryo flash or the fluid bubble, which has a movement. It either moves up or it moves down. And there were other groups also in literature that tried to study whether there's any relevance of this fluid bubble, whether it moves up or down after embryo transfer, whether it improves implantation rate with the movement in a particular direction. So in this paper, a TVS guided embryo transfer was performed, and a second ultrasound in standing position immediately after transfer, allowing the movement of embryo associated air to be assessed. How much did the bubble move? Standing shortly after embryo transfer does not play a significant role in the final position of embryo associated air. And this group said that it's unlikely to be a factor in determining the position of embryos transferred to the uterine cavity when we do an embryo transfer. Transfers, I want to show you it's very convenient. Transfer the entire thing. Very easily wherever you want. Ultrasound guidance our indications for it you want to. So is there a difference now between immediate withdrawal of the catheter versus a 30-second wait? A total of 100 women about to undergo transfer of at least 2 optimal embryos were studied. In one group, there was slow withdrawal of the catheter immediately after embryo transfer, and in the second group, a 30-second delay before a catheter withdrawal. And This and other papers saw no significant differences in pregnancy rates between the two groups. The results indicated that the waiting interval was insufficient to detect differences and that the retention time before withdrawing the catheter is not a factor that influences pregnancy rates. Sometime in 2004, came the SureView catheter and ultrasonic contrast catheter. The SureView combines all the benefits of the classic Wallace catheter with the ultrasoft floppy tip, with the unique opportunity to view the entire length of the catheter. Other catheters have ultrasonic tips, techniques, patented things that only make the tips ultrasonic, but this catheter, the SureView catheter, you can see the entire length of the catheter, and it makes it very easy, not only for the experienced practitioner to do the ultrasound, but for training programs. The juniors, when they are learning IVF and embryo transfers, which I consider the rate limiting step of IVF, the training with the SureView catheters is super. I will just show you how simple it is when you use a SureView catheter. You can see the entire length of the catheter, exactly the 1 centimeter from the fundus. You deposit this is the embryo flash, the embryo with the culture fluid and the air, seen very clearly. You can see it once again for beginners. So it gives a lot of comfort and confidence to the operator when you see the entire length of the catheter. So this is the SureView catheter. And I consider this clip as one of the best teaching clips, a transabdominal ultrasound guidance, how an ideal embryo transfer should be done using a SureView catheter. So you go up, the entire length is seen, the bladder is optimally partially full, and you want to deposit it 1 centimeter from the fundus. The embryo is deposited, the embryo flash gives you confidence, and the catheter is removed. Let's see this once again. This is how an ideal embryo transfer is done. And this makes the training curve very short for the trainees who want to, start their own IVF practices. Another aspect that, we saw, out of experience was fluid within the endometrial cavity just before embryo transfer in IVF cycles, and whether it was associated with failure and what were the options that were taught to us as trainees when we began our careers in 1990s. So removing the fluid with an embryo transfer catheter may be a successful method. And so if you see fluid, we used to use a little larger bore syringe, and with the same soft, ultra soft catheter, we would remove the fluid within the cavity and do the embryo transfer immediately. This was a very interesting paper that told us that made us formulate a SOP, or a standard operating procedure, which has been with us now for 25 years. So this is a paper from Professor Grudzinska's group from London. In 54 patients who had a positive culture tip of the catheter, the pregnancy rate was significantly lower than in patients with a negative catheter tip. Interestingly, all patients with a positive culture of the catheter tip also had positive cultures of the endocervical mucus. And none of the patients who had a negative endocervical mucus culture had a positive catheter tip culture. So it would be logical to assume that washing away the bacteria contaminated mucus would decrease the contamination of the catheter tip and increase the pregnancy rate. So I read this I started IVF in 1990, and in 96, I read this publication. And in this publication, it showed that thick tenacious cervical mucus may not allow the embryos to escape from the catheter, or may surround them in such a way as to prevent them from implanting. They called this the cobweb effect of the mucus, cervical mucus. This can be eliminated if the mucus were removed. Mucus can also trap embryos, and they may stick to the side of the catheter when it is removed. Their embryologists occasionally observed embryos in the mucus stuck to the catheter tip. during examination after the transfer. But whenever we did a vigorous lavage, it results in less mucus and fewer embryos being retained in the catheter. And because we were using ultrasound for almost every 100% of our embryo transfers, and started doing a lavage before every embryo transfer, the ultrasound visualization of the lavage technique at times showed that the culture media hits the, goes into the endometrial cavity. Initially, we were very bothered and concerned that the retained fluid would carry the embryos out of the endometrial cavity. I will show you some videos that were our observations, and initially we were worried about the fluid entering the cavity just before the embryo transfer. But then all these patients in whom we had noticed fluid getting in were the ones who were easily getting pregnant. This fluid that entered the uterine cavity just before the embryo transfer, when we were flushing outside at the level of the external os, flowed back very quickly. On searching the literature, we found that there was one other group that described this phenomenon and reported that the reflux of the culture medium has no deleterious effect and may even enhance embryo implantation. And this is what happens. I will show you. So we were holding an abdominal probe. We do a flushing at the external os, and to our surprise, we find that the warmed culture medium hits the top of the fundus and flows out. This is not an edited film, so within a few seconds, the cavity collapses again. And this is a very common phenomena. Once you start doing ultrasound regularly, hold the probe when you're doing the cervical flushing. And because we had adopted the cervical lavage or cervical flushing, and the assistant was holding the probe, we noticed this very frequently. And we used to not wait immediately after the fluid leaks out. We would use the catheter ultrasound guided, again the same way, and deposit the embryo intended where we want to. You saw the embryo flash go up. So what is this impact of the reflux of media into the uterine cavity on pregnancy rates? So this is firstly a very frequent event, and today we know it enhances the likelihood of pregnancy. This might be because of a self-selection process of easier transfers being more likely to have a reflux. There is facilitation or lubrication of catheter passage by presence of a small amount of media in the cervical canal and uterine cavity, which might be protective to the endometrium. And possibly the reflux media in the uterine cavity creates a more favorable interim environment for implantation in the transition period between transfer and implantation. So how do we do our standardized endocervical lavage? So prior to the ET, a 2 ml syringe filled with the warmed culture medium is attached to the outer cannula of the trial ET catheter. It's an identical SureView catheter. The cannula is gently advanced about 0.5 centimeter in front of the cervical os, so you don't get into the cervix. Forceful squirts of 0.5 ml boluses of the culture medium are injected into the cervical canal, and you allow the gravity to do the rest. Cervical mucus and culture medium can be seen escaping from around the cannula and falling over the posterior lip of the cervix down to the posterior fornix. We never use any gauze piece or anything, or a cotton bud or anything, to clean or touch the cervix. The cervix is just flushed from a small distance, and we allow gravity to take the mucus down, and then we do the trial transfer to just beyond the internal os. After the trial transfer, we inform the embryologist, and she loads the catheter and gets a fresh catheter. After the lavage, the embryos are loaded into a new SureView catheter, and ET is done using the standard technique. This is Professor Hassan Salam's paper very early in 2002, who taught us the importance of molding the catheter. So these SureView catheters are wonderful. They have besides their ultrasonic contrast properties, you can mold this catheter to the shape of the cervical angle, and this really helps us in atraumatic transfers and increasing pregnancy rates. I'll show you a very nice film where Professor Salam's paper can be actually seen in practice. Want to see it for the beginners? Let's thank you for a very patient hearing, and I'm open to any questions at the end or now. Thank you.
Thank you very much, Professor Alabadia, for a beautiful presentation. We have a burning question now, and we'll keep the rest until the end. Somebody is asking, I think it's Dr. Rukaya from Azerbaijan. She's asking if you have embryos remaining in the catheter. You have done your embryo transfer, you are transferring more than one embryo. So one has been deposited and the other one is still in the catheter. What do you do? Do you put them back, or do you?
No, I put them back. And the advantage of ultrasound is the first time, if I put them back at 1 centimeter from the fundus, the next time the retained embryo I can put back at 1.5 centimeters from the fundus. So this happens very rarely. I think over the last few years, I have just done a single embryo transfer, but very, very occasionally after flushing and we have retained embryos, and we generally, I try to just bring it down a little in the cavity and deposit the embryo.
Yeah, so no problem in putting them back, really.
Totally no problem.
There is another question, I think it's from Dr. Azza Rozik from Milan in Italy, about mock embryo transfer. She says that sometimes the uterus changes its position.
No, I never do a mock transfer in advance. We always do. I've just explained that we do a cervical lavage, and same catheter with which I do the cervical lavage, I use it for the mock transfer. And the mock transfer should always be done to only just beyond the internal os. And then you remove it. Then you tell the embryologist, and she loads the embryo, which is to be transferred in another Purview catheter, and give it to us. So this is a well laid out protocol for the last 25 years.
Yes, thank you very much. And we'll leave the rest for the until the end. Then I will leave Professor Michel Abu Abdallah to introduce our next speaker. Michel.
Thank you, Hassan. Thank you, Gautam. Very nice presentation. Now we move to the last lecture, and I'm honored and pleased to introduce my very dear friend, Professor Omar Sefraoui. He's from Morocco, professor and head of the Department of Obstetrics and Gynecology at the University of Casablanca. Also is the founder of IVF Center, a well-known established IVF center in Morocco. And he's president-elect of the Mediterranean Society for Reproductive Medicine and president-elect for the World Congress of IVF 2021. I'm pleased and honored to present Professor Omar. Omar? Omar?
Mute. Okay, sorry. Is it okay?
Yeah.
Yes, we can hear you now.
Okay, I would like to thank Professor Hassan Salam and Professor Michel Abu Abdallah, my very deep friends, to invite me to this very interesting webinar, which is sponsored by Abbott. And I will have the pleasure during these 25 or to 30 minutes to talk about a very important but probably very neglected period within the IVF, which is the luteal phase, and how to optimize it. To introduce my lecture, everybody knows that the luteal phase is the phase between the ovulation and the pregnancy, or the arrival of the menses. It's under control of steroid hormones, cytokines, growth factors. And it's very important to note that there is a luteal placenta at the 5th week. And obviously, there is no need to supplement spontaneous pregnancies, but for IVF and frozen embryo transfer, the question is probably different. During this lecture, I will talk about the role of progesterone. Is luteal phase supplementation required? Does control ovarian hyperstimulation affect the endometrium? When and how give progesterone? What about luteal phase support in IVF and frozen embryo transfer? And some new approaches for the new protocols. Everybody knows the role of progesterone. As you know, it induces the secretory transformation of endometrium, decidualization, and uterine receptivity. It has also an immunomodulatory effect with increasing the nitroxide production, which is responsible of a local vasodilatation and uterine musculature relaxation. It has an important effect on maintaining pregnancy, and to prove that, removal of corpus luteum before 7 weeks leads to a pregnancy loss. There is also an immunomodulatory effect, which is important, which makes in balance the Th1 dependent pro-inflammatory and anti-inflammatory cytokines, which allow to open a window, which is the window of implantation. Primarily, we have to know that for later pregnancy, for the latest period, that means after 24 weeks or 34 weeks of amenorrhea, Kumarasamy and his colleagues made a very interesting meta-analysis and didn't prove any benefit of giving progesterone after 24 weeks of amenorrhea. But for earlier pregnancy, especially with haploid embryos, he proved that giving progesterone is very important to maintain the pregnancy and to reduce the treatment miscarriage and also the recurrent miscarriage. So the progesterone is probably important for this early period of the pregnancy. The progesterone, as everybody knows, is secreted by the human corpus luteum, which has many, many important actions. And we have to know that the progesterone levels is maximal around the mid-luteal phase with around 40 to 60 nanomole per liter. The progesterone increases the endometrial receptivity, even for the natural conception or after the control ovarian hyperstimulation, and allows to open a very important window, which is the window of implantation. To obtain a pregnancy, we need to have a very good synchrony between embryo and endometrium. And for that, we need for endometrium a good receptivity and selectivity, and for the embryo, good embryo quality, aneuploid, with a very high blastulation rates. This is the difference between the natural conception and the control ovarian hyperstimulation. And we see how synchronic is the endometrial and the endometrium and the embryo during the natural conception. But for the control ovarian hyperstimulation, there is an asynchrony between the endometrium and the embryo, which leads to probably a lower rate of pregnancies with IVF. The first question is, does ovarian stimulation protocols affect endometrium in IVF? The response is clearly yes. The luteal phase in IVF is always altered. Why is it altered? Because of several reasons. First, probably the multifollicular stimulation, the higher rates of estradiol and progesterone, which are supraphysiologic, and also all the protocols, agonists or antagonists, can have a deleterious effect on this very important period and decrease the endometrial receptivity. Is luteal phase required? As we all know, in all IVF stimulated cycle, the luteal phase is abnormal. Why? Probably because of aspiration of the granulosa cells. The agonist protocol give an important pituitary suppression. The HCG via short loop suppress LH. The antagonist with the luteolysis phase of the corpus luteum, supraphysiological steroid levels, and also the deleterious effects of controlled ovarian hyperstimulation on the endometrium. We have to know that when we compare normal cycle to hyperstimulated cycle, there is always a gap, which is very important to keep in mind, with a high concentration with the progesterone with the hyperstimulated cycle, but the duration of this progesterone level is very short when we compare it to the normal conception. So that means there is probably a premature luteolysis due to the IVF or due to the ovarian hyperstimulation. This can be also very well demonstrated when we do ultrasound, and you see how the asynchrony between spontaneous cycle, the day of ovulation due to the impact of progesterone, and when for the stimulated cycle, the day of the pickup oocyte, we see how we have still the 3 lines, and the impact of the progesterone is probably at this moment lower than with the spontaneous cycle. There's also some genetic expression which is different between normal and hyperstimulated cycle, and that has been proven in 2005 by Horcajadas when he compared 5 cases control, 1 cycle during the natural cycle and another cycle with hyperstimulation, and he biopsied the endometrium, and he demonstrated that there is a gap or many differences between the normal and the hyperstimulated cycle, especially on leukemia interleukin factor, which is very important for the endometrium receptivity and also for some secreted proteins. So, and he demonstrated there is almost around 18 to 30% of gene variations between normal and hyperstimulated cycles. And this also has been demonstrated also for antagonist protocol, single or several doses. And Simon concluded that luteal phase is also insufficient in generation antagonist protocols, suggesting that the luteal phase deficiency is principally related to supraphysiological steroid levels in the late follicular and early luteal phase. Is there any impact of progesteronemia on IVF? This has been studied by the Thompson and the Humaydan and colleagues, and they analyzed in a prospective study around 600 patients within IVF cycles, and they demonstrated that the best level of progesterone on the early luteal phase is around 18 to 30 nanograms, and when it's higher or lower, the pregnancy rate decreases. And it's also important for the mid-luteal phase, where the optimal level of progesterone is around 47 to 77.5 nanograms. And they conclude that low or high level of progesterone can have a negative impact on pregnancy rates. So it's better to optimize progesterone dose and route in luteal phase. This meta-analysis, old but is still important, published by Pritz in 2002, demonstrated in a meta-analysis that luteal supplementation is very beneficial in IVF. Intramuscular progesterone is similar than HCG, but better than vaginal progesterone, and progesterone rather than HCG due to the high risk of hyperstimulation. And they consider adding estradiol during this period. What about the evidence? Is luteal phase support required to respond? Van der Linden, in this very interesting meta-analysis published in 2015, they demonstrated how important is progesterone with the higher risk, higher chances of pregnancy when we compare to placebo. Which molecule should be used during this period? HCG, effective but risky. Recombinant LH, usable in practice? I don't know, because of the price and the cost effectiveness. Progestin, which molecule? Which way? Dose, duration? And what about the agonist generation? What we know actually is that the estrogens are not really necessary during this period. When and how giving progesterone? We know that progesterone is essential treatment until the relay by HCG in case of pregnancy, but it could be stopped 11 days after transfer, usually until the first ultrasound of 6 weeks at 6 weeks of amenorrhea, and probably no use to continue beyond. We'll see that. And there is no difference in efficacy between the routes of administration, oral, vaginal routes, by capsule or gel or intramuscular, but probably differences in terms of tolerance. Ganesh in 2011 already published an interesting data when he compared Dufaston to Crinon and Utrogestan in 1,300 patients in a randomized controlled trial, and he didn't find any significant difference between the three ways of giving progesterone. What about HCG? We all know that HCG have a positive impact when we give it within the luteal phase, because it stimulates all the function of the corpus luteum. We give it 15 units every 3 days, 2 or 3 injections, but it should be usable only in the absence of risk of ovarian hyperstimulation, as it had been proven by Van der Linden in 2015, where there is a high risk of giving HCG of ovarian hyperstimulation than giving progesterone. When to start? This is a very important question. Mokhtar in 2006 compared the 3 periods, the day of oocyte retrieval, the day of HCG group, and the day of the embryo transfer, and he really didn't, he find a difference between the day before the pickup and the day or the 1 day later after the pickup, where the pregnancy rate increases the day of the oocyte pickup or day +1. Also, in a prospective randomized controlled trial, when they compared the day of oocyte pickup starting progesterone and day +1, there was no statistical difference between the 2 periods. So we can start the day of the pickup or 1 day after without any negative impact. Paradoxically, when we start 12 hours before the pickup, when we compare it to the day of the pickup, or 3 days compared to 6 days of the after the pickup, there was deleterious impact in terms of pregnancy rate when we start before the pickup, and we stay till day 6 after the pickup, and we can say that there is no interest or there is negative impact to start before oocyte retrieval, and certainly not after 3 days after the pickup. So we can say that starting progesterone for luteal phase support should be in the window between the evening of the day of oocyte retrieval and day 3 post oocyte retrieval. What about the routes? Shoam and his colleagues in the worldwide IVF made a very interesting survey a few years ago, and they tried to have an idea about which route is mostly used by the IVF centers. And as we see, more than 75% of the IVF clinics use vaginal progesterone, but some of them use intramuscular and others use both intramuscular and vaginal progesterone. So what about the routes? As we all know, the first one was the parenteral, was the first described, then came oral. The transdermic is probably to forget because the poor permeability of the skin, and at least the vaginal routes has been described. When we compare the two routes, vaginal and intramuscular, Del Prato in RBM Online compared the two routes, and they didn't find any difference in terms of implantation rate and pregnancy rate. And even when we give twice screen-on daily, no difference appeared between the intramuscular and the vaginal progesterone gel. This to demonstrate the same results. And this meta-analysis tried to compare all the routes of progesterone, and they didn't find any difference in terms of implantation and pregnancy rate when we use all these routes of progesterone. But some, and any of the previously mentioned administration routes, non-oral for natural progesterone as luteal phase support can be used. It's a good recommendation, grade A. What about the dosing? Issue recommendation. Dosing of natural progesterone has evolved empirically. Dosage used include 200 milligram 3 times a day for vaginal, progesterone 50 milligram for intramuscular, and 25 milligrams for subcutaneous are the normal doses. And what about the oral progesterone? Since the two phases of studies of Lotus 1 and 2, which has an interest of non-inferiority of Dufaston compared to gel and the vaginal tablets, and they didn't find any difference in terms of tolerance or also in terms of adverse effect associated with congenital, familial, and genetic disorders have been evaluated, and it seems safe to give oral progesterone with also similar pregnancy and implantation rates. When to stop progesterone? This is a very important question, and the Chinese team since 8 years ago tried to compare stopping progesterone the day of HCG to 7 weeks later, and they didn't find any difference in terms of live birth rate or in terms equally of miscarriage rates. And they also suggested to stop the progesterone the day of the pregnancy rates. So when to stop? Probably around the day of HCG positive, stop at 8 weeks, or after 12 weeks. I think there is no reason to go so further. And in the randomized controlled trial published by Mohammed Abulghar, they demonstrated there was no benefit after the first ultrasound with the heartbeat. In this survey published by the Worldwide, you see how there is many huge differences between IVF clinics, and some of them go till 10 to 12 weeks of gestation, and especially in Africa. Why? Probably because it's better to be wise than sorry. And as said La Fontaine, the reason of the strongest is probably always the best. So when to stop? As a recommendation, we can say that progesterone for luteal phase support should be administered at least until the day of the pregnancy rate. What about the agonist to sustain the luteal phase in antagonist IVF protocol? In this very interesting published study in 2019, in an antagonist protocol, they added to progesterone. They had 3 groups, one with only progesterone and 2 groups with 1 dose of an agonist triptolurine 0.1 nanograms, or several injections of triptorelin. And what did they find? For oldest and for youngest patient, there was a real benefit of adding generous agonist during the luteal phase, super phase, and there was no difference between single dose or several doses of triptorelin. So it seems interesting to give one dose of triptorelin, probably 2 or 3 days after the pickup oocytes, and it seems to increase the pregnancy rate, but for patients with lower risk of hyperstimulation. Now, what about the frozen embryo transfer? We all know that this embryo transfer, frozen embryo transfer, has deeply increased within these 10 last years because of the development of vitrification. And this vitrification gave up probably improved embryo survival and also improved pregnancy rates with a better embryo endometrial synchrony. And probably also, since the study published by the Catalan team of Pedro, our friend Pedro Bari, where he demonstrated that within the frozen embryo transfer, the perinatal outcome was better than with the fresh embryos, because the negative, the control ovarian hyperstimulation has probably a negative impact on preterm and on also life or low birth weights when we compare it then with the frozen embryo transfer. Also, the indications of frozen embryo transfer, as you all know, increased probably with the supernumerary embryos, with the single embryo transfer, and also for the genetic development for the screening embryos, or for the PGD, where we need to freeze the embryos and give the haploid embryos within a thawed cycle. What about the serum progesterone in natural and artificial cycle? This is important to keep in mind, and there is a huge difference between the level of progesterone and also as I demonstrated in the previous data, how the progesterone remained high in the natural cycle, and in the ovarian hyperstimulated cycle, we have a very critical decrease of progesterone, which is due to the premature luteolysis. We all know that the vaginal progesterone is very important due to the first uterine fast effect. This has been demonstrated more than 20 years ago, and the serum concentration have not been shown to correlate with the endometrial transformation or the ability to establish and support a pregnancy. What about the route of progesterone, or the cycles, the type of cycles to transfer thawed embryos? Weizmann in the worldwide IVF, in his survey, had this result, and almost half of the clinics use recombinant hormone replacement therapy, and half of the other clinics use natural cycle. So when we compare these two routes, it's important to have, if there is any impact, just to remind you, all the protocols we have in our hands: natural cycle or modified natural cycle, ovulation induction cycle used by clomiphene, tamoxifen, letrozole, or gonadotropin, and at the end, the hormone replacement therapy, when the estradiol at the first period, then add in supplement progesterone and thaw the embryo in function of the day of the embryo. If it's day 3, we should have 4 to 5 days of progesterone. When it's morula, it's 4 to 5 days, and with its blastocyst, normally it's the 6th day of the progesterone. Robara in 2017 compared in a Cochrane database interesting review all the regimens, and he didn't find any, he concluded there was no evidence to support the use of one regimen instead of another. When we use agonists to prepare before starting an artificial cycle. This data didn't find any difference in terms of pregnancy rate when we add agonists, so there is no need to prepare with agonists before starting our artificial cycle. Results are sometimes very different and a huge paradox between data to others. And this interesting data, but retrospective, published by Hatoum, compared around 200,000 cycles and it compared artificial cycle to ovarian induction cycles. And his results, he found early pregnancy loss rate was lower for ovarian induction, ovulation induction, and also live birth rate significantly higher for ovarian ovulation induction when we compare it to the artificial cycle. What about the natural or modified natural cycle? Normally, there is no need to use progesterone, and the only interest or benefits seem for the patients who had a luteal phase defect in normal ovulatory patients, which is around 88%. But we all know that this is not easy to define this kind of patients. When to start for natural cycle? We know that there is no significant difference in terms of clinical pregnancy or ongoing pregnancy rate in true natural cycle, and no difference in outcome in a modified natural cycle. And to conclude, progesterone supplementation in those both cycles is recommended with a very low level of evidence. What about the natural or modified cycle? This is data published in 2018 in Human Reproduction by Blockhill and his team. And what did he find? That there was a deleterious effect of adding HCG, that means for modified natural cycle, when you compare it to natural cycle plus progesterone or natural cycle without adding progesterone. And he concluded that HCG can be deleterious for the receptivity of the endometrium. This Cochrane published 10 years ago also, when they compared the different progesterone routes, they didn't find any difference in terms of impacts for IVF for the several routes. This interesting data published recently by Kevin, Belgium team, where they compared blastocyst transfer used with progesterone replacements as endometrine. When they compared it to the intramuscular one, it was a non-inferiority trial. And what did they find? They found that using progesterone alone have less implantation rates and pregnancy rates than when we use intramuscular progesterone or both. And my concern is probably about the dose, because 400 milligrams should probably is probably a lower dose than we used to use, which the dose is 600 to 800 milligrams. This data is to compare the pregnancy rate with the adding progesterone the day of oocyte or the day +1. And as we said, there was no difference in fresh cleavage stages. And also there was no difference when progesterone was started 1 or 2 days before, or when transfer was performed on blastocyst stage. To synchronize the embryo thawing, we all know that it depends of the type of protocol, and with its hormone replacement protocol, we need to have around 4 days for the day 3 and 6 days for the day 5 of embryo. But when we compare the number of days of progesterone for day 3 or day 5, that means when we give only 3 days of progesterone compared to 5 days of progesterone for cleavage embryos, this published data by Van de Vigever in 2017 didn't find any difference in terms of clinical pregnancy rates. Also, for the blastocyst, giving 6 days or 7 days, transferring the 6th day of this or the 7th day of progesterone, no difference were seen in terms of day 5 blastocyst, but for day 6 blastocyst, they remarked a very higher rate of miscarriage rate when we give less than 6 days of progesterone, and they concluded there was more miscarriage on blastocyst for day 6 if transfer was less than the 7th day of progesterone with the tendency of lower pregnancy rates. What is the optimal progesterone level? This is important to keep in mind, and certainly more now with some new data published very recently. And we know that it's very important to have a look to the level of progesterone in the frozen embryo transfer. And we know that the best optimal rate level is around 15 to 30 nanograms per milliliter. And this data published in 2019, they found that the cutoff of 20.6 nanogram per milliliter have a higher impact in terms of pregnancy rates. This data seems interesting because it's an observational data published by Alsberg in 2013, and he compared 2 ways to give the progesterone gel. The first period where he gave only 1 dose of Crinon progesterone gel, and the other period when he had gave 2 doses of Crinon twice daily, and he demonstrated a higher pregnancy rate and also higher delivery rate and less miscarriage rate when he doubled the dose of Crinon. Is there any impact of low progesterone the day of the embryo transfer for frozen embryo 1? Labarta, these 2 last years, published an interesting data, and she demonstrated that there was a cutoff at 9.2 nanograms per milliliter the day of the transfer of thawed embryos, where the rate of pregnancy rate decreased. But in my mind, in my opinion, every center should do his own opinion and probably should do his own cutoff of progesterone. Labarta also demonstrated how 8.8 nanograms has a much worse impact in terms of clinical miscarriage. And the question is low progesterone predictable? How can we predict low progesterone? Probably to make this level or to this dosing progesterone the day before thawing embryo, and to see if there is any difference between the 2 periods. And what Labarta demonstrated, that there was no difference between the day before and the day of the pickup. So we can already dose the progesterone the day before just to preview any modification of the protocol. And the question, if we predict low progesterone, is it corrigible? This study published also by Labarta, they did a Luteal Phase rescue when progesterone was less than 9.2 nanograms. What was the result? The clinical pregnancy rate were similar when they rescued the Luteal Phase, but for the patients who could not elevate their progesterone, we see that this group showed 20% less ongoing pregnancy rate. So it seems very important to rescue this level of progesterone. So to conclude, progesterone is important for implantation and maintaining pregnancy. The luteal phase support is mandatory for agonist and antagonist protocols. This support should start at the later 3 days after the oocyte pickup. Many controversies about the moment to stop the progesterone. Vaginal route is the most used worldwide for frozen embryo transfer in a hormone replacement treatment. Progesterone should start the day of the presumed pickup or at day +1 maximum. The best protocol for frozen embryo transfer is still not well established. And for frozen embryo transfer in natural cycle, progesterone should be used only in cycles with luteal insufficiency. and monitoring serum progesterone should still be and more evaluated. And thank you for your attention.
Thank you very much, Professor Sefroui, for a beautiful presentation. Let me take my privilege here and ask you a question before leaving the other questions to Professor Michel. We have many patients in Egypt who are afraid of using vaginal progesterone. They think that anything introduced in the vagina can be detrimental. And I'm pleased that you showed the Lotus 1 and Lotus 2 studies showing that dydrogesterone or oral progesterone is as good as other methods of administration. And my question is, do you have any experience in using dydrogesterone or oral progesterone in frozen embryo transfer?
Well, this is an important question. I personally do not use dydroprogesterone for the frozen embryo transfer. I'm still waiting for more evidence. But what we know that there was 2 data published or presented in the last ERC, and they demonstrated that there was no inferiority, non-inferiority using dydrogesterone. I think that Abbott are still working on and I think a Lotus 3 or Lotus 4 for the frozen embryo transfer, but the preliminary results demonstrated that we can use dydrogesterone. And in my opinion, this is a very interesting route, but as you said, Hassan, the vaginal route is horribly not tolerated by the patients. They give them itches. They have very many difficulties to use vaginal tablets. So if you have the proof, as for the fresh embryo transfer, that for the frozen one, it's safe. It's probably safe because there is no difference that with the fresh. And if it's as efficient as the vaginal route, it could be probably the gold standard in the future.
Yeah, because we are using it actually for frozen embryo transfer also, of course for fresh, but also for frozen. And we have good data, but we are in the process of publishing. Thank you very much again. And I'll leave Professor Abu Abdallah to ask some questions. And I will also ask some questions. Professor Abu Abdallah, Michel. Michel?
You're muted.
You are muted, Michel. You are muted, Michel.
Yes. Going through the questions, I have one question from Dr. Hussein Hilal, and most probably it would be directed to Professor Omar and Professor Gota. In preparation for the endometrium for embryo transfer, some are adding estrogen, progesterone, and HCG. Is it true, effective, or not?
You are talking about the frozen embryo, thawed embryo transfer, not the fresh.
Well, he's not specifying. He said in preparation for embryo transfer.
If for the frozen embryo transfer, there is no good data about adding HCG, specifically when we use hormone replacement protocols with estradiol and progesterone. But for the fresh embryo transfer, what we know that for the estradiol, I think that there is no benefit to add estradiol for all the patients. That's already has been proven. But for the HCG, we can, as I said, give 15 units, international units of urinary HCG, or 2,000 units of recombinant HCG. We can give it once, or for 3 times every 72 hours, every 3 days, but specifically for patients with lower risk of hyperstimulation syndrome. This is very important. And it seems that there is some benefit, as I said, and even also for the agonist. I think we should keep in mind that giving 0.1 nanograms of triptorelin the day of the transfer, if we do the transfer on day 3, or 2 or 3 days after the pickup, as I mentioned, I think it has real benefit. And we used to do it since 2 years, but for patients that has a normal or low response. And we didn't do it randomizedly, but we really saw a real benefit of giving agonist the 2 days after the pickup.
Well, actually, in our cycles of egg donation, usually we continue throughout the luteal phase with estradiol 2 milligram and sometimes between 2 to 4 milligram to the heavy load progesterone. So, and it seems that this protocol has been adopted, especially in the egg donation programs.
Well, unfortunately, I have no experience with egg donation because in my country, it's allowed. But we can, the protocols are similar for donations for the recipient as for the non-donated oocytes or embryos. And it's important to keep estradiol. Our protocol is simple. I can give my protocol is 4 milligrams for 7 days of estradiol. Then we go to 6 milligrams. We do ultrasound on day 12 or 13. And if it's the endometrium is more than 7 millimeters, then we add progesterone. We keep estradiol, but we sometimes decrease the estradiol to 4 milligrams. So 2 pills, 3 pills, and then we decrease to 2 pills, and we add 600 to 800 milligrams of vaginal tablets of progesterone. And for the transfer is done when we use HRT. The transfer is done after 4 days of progesterone when we do cleavage embryos, day 3, and 6 days of progesterone when we use blastocyst. But as I saw, many data has demonstrated that there was no difference between 3 or 5 days of progesterone for day 3 embryos and 5 to 7 days of progesterone. Only the difference is only for the day 6 blastocyst when they remarked a higher miscarriage rate when we give lower period of progesterone.
All right, I have 2 questions for Professor Kovacs here. The first one is about, is there any role for time-lapse photography in sex selection? For example, some people think that rapidly developing embryos can be male. And the other question is, which one of the parameters is more important? Is the time to the event, or is it the cycle, the CC or the S? The synchrony, or is it the cell cycle, or is it the time to division?
Yes. Yeah. I'm not aware of any data on sex selection, so I have not read any papers that were able to select the embryo based on either cleavage timing or cleavage pattern. So I don't think that this is good enough for that. I certainly, even if there were some kinetic differences, I believe that there would be such a huge overlap that I doubt that this could be useful for that. In terms of the second question, various algorithms use various markers, and usually they combine both the cell cycle and the synchrony of the divisions and one kinetic marker. So it's usually, let's say, time to the 5 cell stage and first cell cycle and second synchrony that is considered. But I don't think that these algorithms will be used for a long time, because artificial intelligence can analyze everything at the same time, and there will be no single parameter that is useful. And actually, we will not have to deal with checking these times and measuring the duration of the cell cycle or the synchrony. We just put the embryo in the time-lapse unit, and 3-5 days later, it tells us the ranking, and then we can just select the embryo, and we don't even have to know what the artificial intelligence does, how it selects the embryo.
Yes, we're very helpful, hopeful about artificial intelligence. I don't know if you know about our work, which we published in RBM Online many years ago with Professor Petresi from Italy. We took the pictures of the embryos, but this was the before the era of the embryoscope, and we converted this. We did the image analysis as you did, and we converted it into a vector, and we actually trained the computer, and then the computer could recognize, yes, but we didn't take this to a prospective randomized study. So really, everything needs to be tested by randomized controlled trial, I think. It's not
Exactly.
only...
And that is actually ongoing. Vitrolife is currently doing a study with testing this their artificial intelligence system called IDA-Score. So it's not currently available yet, but hopefully it will be available soon.
Yeah, are these studies done on single embryo transfer? Because it will get you the result quicker.
But even if it is not done on single embryo transfers, you separate your data. So your all negatives are whenever you transfer 1 or 2 embryos, and if there's no pregnancy test, then you know that both embryos are negative. If you transfer 2 embryos, you can only include those cycles where both implant, because then you know that both implanted. If you have a double embryo transfer, one implants, one doesn't implant, you don't know which one is which.
That's where the problem is. Yes, of course,
Yeah.
Professor Kovacs. Oh, thank you very much. Michelle, you maybe have other questions.
Yeah, I have a question for Professor Yahya. That comes from Muhammad Asim. Do individualized dose can help in cases of polycystic ovary with resistant response during ongoing cycle?
Actually, if I'm speaking about standard dose, this doesn't mean that you can increase or decrease. Obviously, you see a patient at day 7, and then you can gauge the response and increase and decrease accordingly. But the problem is, if you are having a resistant PCO patient, these are the patients you need to do some step up in these patients. And obviously, you'll need to step up. If you want to step up after 7 days, you are allowed to do that. And you go on as long as it takes to get you to your results.
Yes.
Another question for you, Muhammad, from Muhja Falah. The possible effect of high FSH dose, is it due to premature progesterone rise or another effect on endometrial receptivity or top quality embryos?
We have spoken about that before, but I think from the literature that it's actually a direct effect of FSH on the endometrium. Otherwise, I don't think the embryos are affected because we transfer them in subsequent cycles and they do implant.
Okay.
All right. There are some questions for Professor Labadia. Somebody is asking, do we need to have a full bladder to see ultrasound, ultrasound embryo transfer properly? Because all the videos you have shown had a full bladder.
It's a partially full bladder. It should not be too full. It's a partially full bladder for trans-abdominal transfers, and for the transvaginal transfers, obviously an empty bladder.
Okay, and the other question is, can we use vaginal ultrasound then?
Yes, I showed you a video of vaginal ultrasound. I mentioned that for obese women, And if you're doing a lot of transfers and somebody lands up with an empty bladder, then you use transmission guidance to complete the embryo transfer.
Okay, two more questions. Can you do anything during embryo transfer to prevent or diminish the incidence of ectopic pregnancy? Is there anything wrong that people do that, for example, injecting the fluid forcibly? For example, does this?
There have been a lot of publications which have examined the speed of injection, the amount of fluid, whether the embryo flash moves up, down, or towards the corner, but nothing has been, statistically proved significant in preventing ectopic pregnancy.
Okay. Any role for uterine relaxants?
Again, it's not really proven to be within the ambit of evidence-based medicine.
No, no. Any role for the embryo glue, the substance people add to add the embryo to stick to the wall? All this.
I think it's a misnomer, the word embryo glue. So
Yeah.
just a marketing strategy.
Yeah. Maybe Professor Abu Abdallah, I think there are plenty of questions. I don't think we can go on forever. We have been already for 2 hours, 20 minutes. So
Well, I have a question from Magid Karras. What about transfer with the sheath in difficult transfer? Gautam.
What about transfer with the sheath?
Yeah, sheath.
Okay, so exactly, if you do a partially full bladder, and most of our transfers have had a pre-IVF hysteroscopy done in the previous month. So I think out of 100 transfers, we come across one transfer where, despite all this, you might have to use the sheath. So if you set up a proper SOP in your clinic or clinical practice or group, the incidence of difficult transfers goes down to less than 1%.
Okay.
Another question for Professor Labadia, anonymous attendee. If we use the embryo transfer, as you said, for the trial embryo transfer, we use the same catheter for the actual transfer?
No.
So you use two transfers, two embryos, two catheters.
Yes.
Yes. Yes.
The first catheter can be a non-echogenic catheter, which is it's relatively half the price, and the other one is a SureView that we use for actually transferring the embryo.
Yes. So I think, Dr. Michel, it will be the last question for the sake of time. And if you have any question, there is another question for Professor Sifroui.
Well, actually, I'm done with the question. I would like to thank you again for inviting all the region to this very interesting webinar.
Yes, and beyond the region, actually, we had 1,400, and I think we went over 570. Of course, not everybody goes on. The last question for Professor Sifroui is corticosteroids. Do you use corticosteroids? Do they have a role for? And also Viagra, do they have a role in preparing the endometrium, the sildenafil?
Viagra has been used by some teams just for thin endometrium.
Yeah.
We really didn't see any benefits. And there was no more data according to this procedure. For the corticoid, some studies try to demonstrate the benefits of dexamethasone, but unfortunately there was no benefit adding corticosteroid. I think that's the only, if we use, it depends on the protocol, just to be brief, progesterone, supplementation of progesterone is probably the worldwide accepted way to support the luteal phase. And we can add for some patients agonists specifically for the fresh embryo transfer for patients who has no risk of hyperstimulation. Because we know that giving triptorelin during this phase can increase the risk of hyperstimulation.
Well, two final questions. Can we? One of them is the combining dufaston with vaginal progesterone. Can we do this?
Sure, we can do this. The problem is with the Dufaston, if you allow me, the drogesterone is not measurable for the frozen embryo transfer, and this is probably a handicap for measuring. As I tried to explain in my last data or slides. Measuring progesterone is very important, specifically for frozen embryo transfer. But there is one data I saw in 2020 published in ERC. Many people can find them in the ERC, where they combined vaginal progesterone with the dydrogesterone, 20 milligrams, 2 tablets, and they demonstrated that the results were increased when we compare it to the vaginal tablets alone.
Yeah, we also do this, and very successfully. And we started measuring actually to see. And the last question is, what about Fizol for all? This is from Ismail El Dawa, the other one for Mahmoud Jihad, the combination. And Ismail El Dawa is saying, could we freeze all as routine to increase the success rate?
I certainly don't agree with the freeze-all procedure for all the patients. To be brief, the most important thing is to individualize cycles and the way to do the transfer. There is probably a very good benefit for the hyper-responders to freeze embryos and to do the freeze-all. But for the normal and for the lower responders, there is no benefit at all to go for the freeze-all. And the only way to do freeze-all probably is when progesterone increased or is higher than 1.5 nanograms per milliliter. The day of the triggering, the day of the HCG, this is the only indication for us to freeze all the embryos, but we really are not adept of the freeze-all at all. We need to individualize cycles. This is very important.
Yeah. So only it's Dr. Shapiro from Las Vegas, who is the champion of freeze-all for all. I think with this, we come to the end of this webinar, and I really would like to thank our speakers again for their time and for sharing their knowledge and experience with us. Professor Mohammed Yahya from Cairo, Professor Peter Kovacs from Budapest, Professor Gautam Alabadia from the United Arab, from Dubai and from India, and Professor Ahmed Sifrewi from Morocco. I want to thank my co-chair, Professor Michelle Abu Abdallah, and the sponsors of the meeting. Abbott, of course, thank him very much, and also Booster Bees, who have been running this webinar. And thank you. Maybe Michelle, you want to say something?
I want to thank you again and thank the speakers for accepting to join. And hopefully we will meet again in another webinar.
Okay, inshallah.
Thank you very much.
Take care, everybody. Okay, and thank you again very, very much. And
thank you.
À la prochaine, as we say.
À la prochaine.
À la prochaine. Oui. Bye-bye.
Bye.
Peter and Gautam and everybody, and I'll see you soon after the corona is over.
Hopefully. Bye, Peter.
Are we off, or are we still on? Dr. May, are we?
You're still on. If you want to continue for a while, it's okay, Doctor. We have 30 minutes left.
30 minutes.
I mean, the audience are off?
Oh, the audience, no, not yet.
Okay, right. Okay, so anyway, we'll continue our discussion later, Michelle.
Okay.
Later.
Bye-bye. And have a nice weekend, all of you.
Thank you very much, Dr. May and Booster Bees and Michelle.
Yeah, thank you.
Okay.
Thank you.
Bye-bye. Bye-bye. Babur. Okay. I will tell him. The Babur.
Please.
I will convey.